Hi everyone, I'm Dr. Osman, a cardiology fellow, and today I want to talk about two blood tests that almost never get discussed in a regular checkup, but can completely change how we look at your heart risk. You've probably heard of LDL, the so called bad cholesterol. For years, most of our focus has been lower your LDL and you lower your risk. That's still very important. But we know now that LDL alone doesn't always tell the full story. Two markers, ApoB and lipoprotein a, also called Lp(a), can help explain why some people still develop heart disease even when their LDL looks fine. My goal in this video is to explain in simple language what ApoB and lipoprotein(a) are, why they matter, who might benefit from getting them checked, and how they fit in a bigger preventive heart health plan with your own doctor. This is not personal medical advice, but it's something meant to help you have a more informed conversation at your next visit. Let's start with LDL. When we measure LDL on a lab report, we're usually measuring how much cholesterol is inside the LDL particles. Think of it as the cargo. But here's the key, it's not just how much cholesterol you have, it's also how many particles are carrying it. Each of those particles can slip into the wall of an artery and help form plaque. So if you have a lot of these particles, your arteries see more traffic, more chances for plaque buildup, and more risk over time. Now that's where ApoB comes in. ApoB stands for Apolipoprotein B. You don't need to remember the name, just remember the picture. Imagine your bloodstream as the highway. LDL, VLDL, remnant particles, and lipoprotein(a) are the trucks carrying cholesterol and fat. Each truck has one ApoB license plate on it. So when we measure ApoB, we're basically counting how many cholesterol carrying trucks are on your highway, not just how full the trucks are. Now, why does this matter to you? Large studies and major guidelines have shown that ApoB often predicts heart attack and stroke risk better than LDL alone, especially if you have high triglycerides, have insulin resistance or diabetes, are living with obesity or metabolic syndrome. In some people, LDL may look okay, but ApoB is still high, meaning there are more particles than we'd like and more opportunity for plaque to form. Typical targets your doctor may think about, and this is not one size fits all, by the way. For many patients at moderate risk, ApoB below 90 milligram per deciliter is often considered reasonable. For people at a higher risk, like those with known heart disease or coronary disease or prior heart attacks or strokes or very high risk, many experts aim for below 70 milligram per deciliters and sometimes even lower depending on the situation. Again, these are general ranges, not personal goals. Your own target should be decided with your own clinician based on your full picture, not just one number. If ApoB is high, your doctor may look more closely at your lifestyle, consider intensifying cholesterol lowering medications like statins, ezetimibe, or PCSK9 inhibitors, and reassess your overall risk, not just your LDL. Now let's talk about lipoprotein(a) or LPA. LPA looks a lot like LDL. It's another truck on that highway, but it has an extra protein tail called apolipoprotein A attached to it. Now that tail makes it stickier, more likely to promote clotting, more likely to irritate and inflame the artery wall. Here's a crucial point. Your Lp(a) is mostly genetic. It doesn't change much with diet, exercise, or statins. Some key facts we know from large studies and scientific statements are roughly 1 in 4 adults have elevated Lp(a), and Lp(a) is associated with higher lifetime risk of coronary artery disease, strokes, aortic valve narrowing, also called aortic stenosis, And this can be true even when LDL and triglycerides look normal. So most people have never had it checked. Typical threshold often see Lp(a) below 50 mg per deciliter is often considered more reassuring. Levels above that are associated with higher lifetime risk and considered a risk enhancing factor in many guidelines. Right now, we don't have widely available medication that specifically and safely lower Lp(a) with proven outcome benefits. But several promising drugs like pelacarsen and olpasiran are in advanced clinical trials and can lower Lp(a) levels dramatically in early studies. We're waiting on outcome data to see how much they can actually reduce heart attacks and strokes. So what we can do today, if your Lp(a) is high, the focus becomes getting LDL, Apolipoprotein B as optimal as possible. Tight control of blood pressure, blood sugar, weight control, no smoking, paying attention to other markers like inflammation. In other words, turn every other risk factors down to balance that genetic up from Lp(a). You might be thinking, so who should even consider these tests? These are not necessary for everyone, but they can be particularly helpful in people who have strong family history of early heart disease or stroke, have had a heart event that doesn't fit the typical story, have high cholesterol that doesn't fully explain their risk, have diabetes or metabolic syndrome or high triglycerides where ApoB becomes extra clarity, and are already on treatment but we're still unsure if their risk is truly under control or not. Both ApoB and Lp(a) are simple blood tests, are relatively affordable and widely available in many labs. Only need to be repeated occasionally once in lifetime. That is true for Lp(a) unless there are major health change. ApoB may be repeated to track response to therapy. If your results show high ApoB, your provider may adjust medications or treatment intensity. High Lp(a), the plan usually focuses on tightening control of everything else while we wait for specific therapies and more outcome data. So let me share how I think about this in the clinic. I often meet people who've done everything right, eat reasonably well, they're active, they're exercising, they're sleeping okay, but their LDL doesn't look terrible, they yet and still end up with coronary artery disease. When we dig deeper, ApoB and Lp(a) often help explain that hidden risk. ApoB tells us how many cholesterol carrying particles are hitting the artery wall. Lp(a) tells us if there's a genetic, stickier pro-clotting factor we've been missing. Now, for the right patient, these numbers don't just give more data, they change the conversation. Do we need to be more aggressive? Are we truly at goal? Or do we just think we are because the LDL looks okay? Are there family members who should be screened? And I want to be very clear, this doesn't mean everyone should run out and order these tests on their own. Lab tests should always be interpreted in context, your history, your medications, your family story, your overall risk. But if you are someone who has a strong family history of early heart disease, have had heart problems that feel unexpected, or if you're already high risk and we're trying to really personalize prevention, then it's very reasonable to ask your clinician, would it make sense in my case to check an ApoB and a lipoprotein(a)? That simple question can often be a deeper, more precise conversation about your prevention plan. Now, to sum it up, LDL is still very, very important, but it's not the full picture. ApoB counts the number of cholesterol carrying particles, the trucks on the highway. Lp(a) reflects a genetic, often silent risk that many standard panels miss. For the right person, these tests can help move from one-size-fits-all approach to precision prevention. As always, this video is education only. It is not medical advice and not a substitute for seeing your own doctor. Never start, stop, or change medications or treatment based on a video. Instead, use this to have a more informed, meaningful, thoughtful conversation with your own clinician about what's right for you. So, if you found this helpful, hit like, subscribe for more heart health content, and feel free to share this with someone who's been told your cholesterol is fine but still worries about their risk. Thank you for watching, and I'll see you in the next video.